on the Minister of Public Health and advisor to the Minister. And we are developing together with other colleagues in the Ministry, you know, a program, an idea of a program at the moment on behavioral insights. As you know, this is a very important topic, and which has been part of the public discussion and the discussion in public health for many years. It's a complicated and very sophisticated discipline, but in many cases the application of this discipline has been, let's say, amateur, not really done in a very scientific way. Qatar has been very pioneering in this area with the B4D unit of the Supreme Committee, which was head by Fadi Maki, that we will listen to later. And we are now, the country is now taking the attitude of developing this type of function within the health system, following the resolution that the World Health Assembly just a few weeks ago approved, inviting countries to develop this function. So we are just, we are pioneering, let's say, this type of approach in the Middle East, although there are, you know, experiences done in the past. There's been units set up in several countries, but still is an embryonic type of development. We are trying to invest in this particular area. So I would like to thank the Qatar University for hosting us in these very beautiful premises. And I just read today there is a memorandum of understanding signed by Qatar University and the Minister of Public Health yesterday. I don't know, I said that's, we celebrate also this today. And so without any further time, I would like to invite to the stage Dr. Timothy Chadbourne. Tim is an expert on behavioral science and is working in the WHO, in the headquarters in Geneva, in this new area of work of the behavioral insight unit. So, Tim, the floor is yours, and afterward we will listen to Fadi. Thank you.
Thank you very much, everybody. And thank you very much. Very honored to be here, providing the first part of this seminar. It will be followed by my colleague, Dr. Fadi Maki. As Roberto said, I'm Dr. Tim Chadbourne. I work in the World Health Organization Behavioral Insights Unit. This is a fairly new unit. We've only been established for about a year, and we went through a period of 2 years of incubation before that point. I've fairly recently joined. For the last 10 years before that, I established and then led a behavioral insights unit in Public Health England, which became the Department of Health, and so part of the Department of Health and Social Care in the United Kingdom. So I've been doing this work for about 10 years, applying this to public health. Part of 25 years of working in public health in my career. And I've also done a lot of work in monitoring and evaluation, quality improvement, and I've spent some time as the president of the UK Evaluation Society. So what you'll hear today, there's a lot of behavioral science and evaluation very much closely together in this approach. So I want to give you a little bit of an update on the latest behavioral science. We do think there's been a real kind of increase in the practice of behavioral science, and it's spreading globally. Really have seen that growth both in international organizations such as the World Health Organization, but also national governments, but also in private organizations. You've seen many, many more advertisements for behavioral scientists in all sorts of organizations. This is some work done by the OECD. This is not just about health, this is broadly, but a few years ago you see there's many, many different countries now applying behavioral insights to public policy. They are focused in Europe and the United States and maybe Australia. As Dr. Roberto said, there's a few, maybe a couple in the Middle East, but they're still kind of forming, and there's still a huge potential to apply this to public health. So what does this mean? I'm going to ask people to engage from the audience, if that's okay. Can you please let me know what the behavior is in this slide? Some of you may have seen this before. What's the behavior? Hand washing. What are some of the barriers and enablers to hand washing for this young girl? Sorry? Access to water, clean running water, so sort of environmental support. Anything else you can see? There's a mother, there's sort of support, social support. There's going to be some education and learning. You might see the soap on the ground. So there are some facilities, but they may be limited. This is another example of mask wearing. I did another presentation just this morning actually around One Health, and one of the questions was about mask wearing. What do you think some of the enablers and barriers are for people to wear a mask appropriately? Any thoughts? Any thoughts about, any thoughts, do you remember when you were kind of wearing a mask every time for COVID, and what's some of the things that made it easy or difficult to wear a mask appropriately? Yeah, please. So where eating or certain activities might make it difficult to wear a mask. Anything else? Yes, please. Sorry? Communication. So because you want to communicate and it makes it difficult to communicate. Yeah. One of the things we saw is that often people didn't have them with them. They just forgot. They got to a place where it was important to wear a mask. They'd been outside or they'd been traveling alone in their car maybe. They forgot to wear a mask. I guess then there's also aspects of knowledge about how to wear a mask and how to put it on properly. Some people wearing it more on their nose or their chin. So there's knowledge aspects as well. Another one here, more the health services aspect and medication. The behavior here is taking medication. What are some of the barriers and enablers there might be to taking medication appropriately? Being able to read the small print. I've definitely recently turned 50 and taking my glasses everywhere with me now. I've never needed to before. I find it so difficult to read the instructions. Absolutely brilliant. That's a really good way because now you're thinking about someone's physical capability. Brilliant. Any others? Does everybody always take all of their medication, finish all of the course and take it all at the right time every day? There's lots of other things that get in the way, aren't there? There are social pressures, there are other things that might happen. So these are just a few of the behaviors. There's a huge number of behaviors, and the next slide just sort of highlights the scope of behavior is so broad in health. And we see those within the behaviors of the public and patients. And those are things we might think about, the first things we think about when we think about behaviors in health. We might think about exercise and diet. We might think about immunization and not wearing masks, things like that. But there's also that more secondary prevention of screening and filling scripts for medication. There's lots of behaviors of healthcare professionals that are really, of patients engaged with sort of more secondary prevention that are really important. And then for patients who have conditions, there's that sort of tertiary prevention where we're thinking about attending health services, rehabilitation, medication adherence. Some of those things are really difficult to do, particularly on a long-term basis. But we can't forget the behaviors of healthcare workers. There's just a few there around hand hygiene, doing the right diagnostics, the right time, making the right referrals to the right services, prescribing, particularly antibiotic prescribing has a high profile at the moment, is a big issue. Lots of issues of, lots of behaviors of healthcare workers that are important. And then there's other things of the public that we sometimes think more about, the social determinants of health, which are really important behaviors that have impacts on health. We have things like parenting, violence, air pollution, active travel or safe driving, road traffic accidents. So we think about road traffic accidents, but we need to think about the behaviors that are involved in that. So this is just to really make the point that the scope of behaviors is really broad. There's a huge amount of potential for application. And also, apologies, it's because I've blown it up so big that it's a little bit unclear. But this slide is about the impact of behaviors. So the reason this is important is because people's behaviors cause disease and death. And this is why behavioral Global Insights focuses on changing behaviors or maintaining good behaviors to reduce our burden of disease. And from the global burden of disease, you can see some of the top issues in terms of their disease burden in disability-adjusted life years. So the scope of behaviors is broad, the impact is broad. So behaviors are important. I mean, if we can take that as accepted, we need to then understand behaviors well if we want to think about changing them. So another little bit of interaction. What makes us behave as we do? If you can all have a little think for yourselves about something that you would like to do that would improve your health. Have a think about maybe something that is difficult, you're finding difficult to do, you're not doing always as you would, and some of the reasons why, or a reason why you're not doing it. Would anyone be comfortable sharing some of their thoughts? I'm sure we must all have similar things. I know I do. Anyone have any thoughts about behaviors, health-related behaviors? Yes, please. Physical activity is a great one. You want to share why you're, what you would like to achieve and why you're failing, maybe it's not so easy? So the example there is about physical activity, not having enough time, but really needing to make time. There's an interesting aspect there around there's a sort of aspect of not having enough time. I guess there's an aspect of prioritization and motivation too, right? And I guess we're probably all familiar with the aspect of physical activity where we go through periods where we're really, really, really definitely going to do it tomorrow. And then tomorrow comes around and we maybe don't do it. Are there any other things people would like to share? Any examples people would like to share? Or I can move on. But I hope you would just think about yourselves. We all face these challenges in terms of behaviors. And I guess what we've been talking through a little bit already is about thinking from a behavioral perspective. And there's a behavioral scientist kind of working in public policy. This is the kind of mindset that we have, is around thinking, what are those behaviors? What are those influences on behaviors? So would you mind if I come back to you and ask, which of those do you think is holding you back from doing it? Convenience, around the time, availability of time. Great. So then one of the ways we think about things, and actually is about trying to break down our understanding of what is driving behavior or the influences on behavior into different categories to help us think systematically and structurally about it. And actually we find out that many of the things actually kind of around convenience, or maybe around motivation, whereas sometimes our responses in public health are very much to kind of address knowledge factors. When we think about it ourselves and we go through the process, it helps us. One of the models, one of the frameworks that we have, this is a model of behavior called COM-B. So we start with behavior, and then there's three key aspects of that. This is capability, opportunity, and motivation. C-O-M and B for behavior. You can see capability is mostly around can someone do it? Motivation, do you want to? And opportunity, does the environment enable them to do it? And as we were just talking about, the opportunity can be really quite a key one. So all these factors influence each other. So even behaviors can influence motivation. And likewise. But the motivation for a behavior has to be greater than the motivation for another behavior. If you're thinking about physical activity and you get home from work and your options are to sit on the sofa and watch TV or go for a walk, go for a swim, then you have competing behaviors and competing motivations. The motivation for something has to be greater than the motivation for a competing behavior. That's a key part of the model. So some of the good reasons to use a behavioral theory are that it helps us describe the process. Oh, sorry, I don't know why that was on it's on a timer. It helps us describe the process of change. It explains how things relate to each other, and it generates as a prediction. One of the key things that we're interested in behavioral science is understanding things and be able to create a response, a public health intervention. For that, we need to be able to sort of predict why things are happening and what will work to change it. So what do we mean by behavioral insights? How might this be different from a communication for health or a health promotion activity? Here's a slide that we've put together at WHO to sort of help think this through. And starts off with the point where behavior is something that anyone does in response to an internal or external event. Something you can observe, you can see behavior, you can see people doing it. We have all of these different sciences and disciplines, and there may be more, but many different disciplines are kind of feeding into the behavioral sciences, the scientific study of human behavior. And the outcomes or the lessons from that really kind of give us those behavioral insights, the lessons about human behavior. And from those we can apply those to behavioral interventions that seek to change behavior by drawing on those insights. So that's how we sort of see these different terms. It's a bit confusing because people use different terminologies around this space, and there's a lot of difference in application, but this is maybe one way of thinking about it. Some of the other things that are new are captured really nicely in this paper by Professor Kelly and colleagues. One is it's just common sense. Another, it's about getting the message across, and also that knowledge and information drive behavior. We just talked about that a little bit earlier around the example of physical activity and thinking about convenience and those different drivers of behavior, the capability, the opportunity, motivation. So we need to think about that more holistically, rather than just thinking about knowledge and education. Another key aspect around behavioral insights, the application of this in public policy, is really around drawing on the theory, but really using the data and evidence to drive our work as much as possible, using rigorous evaluation and really having an evidence and data-driven process, trying to avoid too many assumptions and really bringing evidence into public policy. One of the frameworks that we use, we've developed at WHO with advice from our technical advisory group, is this framework. It's a process framework. It's not a behavioral theory or model framework. It's really about the process, the steps you go in a project that tackles from a behavioral approach. So you can see we have define, diagnose, design, implement, and evaluate. We start off by defining the problem in terms of behaviors, diagnosing the barriers and enablers to behaviors, as we've talked about already, designing the strategy, implementing the strategy, and then evaluating to drive learnings. It's not always a neat linear process, and you can see that there are processes of redesigning, re-diagnosing that happen through the process. But I'm going to sort of take you through each of those one by one, starting with define. So it's really helpful if we have a good definition of what the behavior is. Here are some: do more physical activity, take your medicines, eat healthy, wash your hands. Any thoughts in terms of whether these are good definitions of behaviors? I see a nod. Not specific. Maybe these are not enough. Let's think about, what about these ones? Are these better? More specific? Much better. We would actually like to go even, we'd like to push it a little bit further, even. So when we think about define, we like to think about some of these questions. Who needs to do what differently to achieve the desired change? Where do they need to do it? When do they need to do it? How often? With whom? In what context, for example? And you can see the example there about maybe dental health among children. The who is the children. They might need to brush their teeth. They might do it at home, after breakfast and dinner, twice a day. They might need support from their parents, and they need that environmental support of toothbrush, toothpaste, running water. So this, we really try to get to defining the behaviors as clear as possible. And then we can move into diagnosis. And this is really important to think about the different types of behaviors that we're thinking about. They can be, there's a nice table here that has two things highlighted. So just when we're thinking about this, a really nice paper from colleagues, Professor Rimar and colleagues, around sort of COVID behaviours. And some of these were very different. They're very different attributes. If you just look at those examples of wearing masks and vaccination, wearing masks has that high repetitiveness. You're kind of doing it all the time. There's very low cost, and there's very high public visibility. Everyone can see your behaviour or not. For vaccination, actually, you just do it once, twice, 3 times. The cost is maybe medium. You might need to travel to a place, and you might need to take time away from work or other income-generating activities. And then there's maybe not so much of a public visibility. People might see you going, might see you queuing, but they can't see it all the time. So we need to think about all of these behaviours in very different ways and be aware of this. And it brings us back to this framework that we just talked about. This just shows you there's a slightly additional layer to the framework where it breaks each of those key categories into 2. So the capability is broken into physical and psychological, motivation into automatic and reflective, and opportunity into environmental and social. And you can see the kind of associated questions, which just takes it a little bit further detailed than we had before. So it's another slightly interactive exercise here. Could you kind of share with the group here examples of things that you think of as influences when you're shopping at the supermarket? What might be the influences on people when they are buying foods? Fantastic. You're not giving the rest of the audience much chance. But there was another one. I like that one. Who said, "Oh, please"? How hungry you are. Absolutely, it's a great one. Hunger is a really good one. Advertising. Promotions. Eye-level shelf, where things are positioned. Absolutely. The branding, the colour, how catchy it is to your eyes. How healthy it is? How bored you are. I'd be interested to hear more. Did you have another one? So I thought I saw a hand. Budget, absolutely great. You can see there's so many different influences. And again, just an opportunity to highlight again, how many of those were about knowledge of what's healthy and what's not? It's definitely there, but so many of those different things were not about knowledge. So that's really good. This is me and one of our colleagues from the Western Pacific region when we did this exercise. So this is just a sort of a worked example of some different ones. And again, if we think about, I'm very mindful of my health. I always look at the nutritional labels. If you think about that, do you think that's an example of capability, opportunity, or motivation? Which kind of category would you put that in if you're thinking about this framework? I'm mindful of my health. I always look at the nutritional labels. So I'll do the first one for you. So this we think about this as a reflective motivation, really kind of consciously weighing up the pros and cons and taking a conscious attention to the issue. Oh, this is me. This is me. I don't know how to cook, so I usually buy pre-made meals. Psychological capability. Psychological capability. Fantastic. I'm trying to stick to a budget. That was the point made. So I only purchase what's on sale. I think I heard a little bit louder. Environmental opportunity. So around cost pressures. My children pester me for all their favourite foods. Anybody? Is there a difference when you walk around the supermarket when you're on your own versus when you have your children or your partner with you? What would you say this? Social. That's social opportunity. I don't have a car, so I can only buy what I'm able to carry home. Physical capability. And I'm persuaded by the latest offers and promotions. more automatic motivation, right? That's more of the persuasion, the automatic emotional kind of responses. So again, it shows you how the framework can really help us and be comprehensive and structured in the approach. So one example of this is some work that we did in Malaysia when we're looking at the uptake of COVID booster vaccination. 3 in 4 people from the national survey were willing to take a booster vaccine, but there was still quite a substantial proportion that were not sure. And one of the things I just wanted to highlight in this, which is quite nice, is that we had different methods of collecting data that would help us give us information on why people were doing this or not. So it was a rapid literature review of existing evidence, a rapid analysis of existing behavioral data, focus groups, and also theory-based assumptions. We can draw on the theory to give us clues. And this is the COMBI model again in a wheel of capability, opportunity, motivation. You see those 6 factors, and some of the different things that we found through that research are categorized into those factors. And just to highlight a few of those, there was usually the theory told us that people would know how to book and know how to get to the vaccination site. There wasn't any specific information on that, but the theory told us that that wasn't necessarily going to be a problem. But social media monitoring gave us information that public trust was actually going to be quite key in this, particularly trust in government, trust in the authorities. From the national survey, kind of confirmed what we might have thought from some of the theory around risk perception and the importance of risk perception. Focus groups told us that that for people who are sort of living at home, they'd already had a booster, and we're talking about the they'd already had the vaccine, and we're thinking about the booster now. They didn't have a problem getting to the same location if they'd been before. They knew how to get there, they'd been before, they'd done it. But actually students said that if they're away from home, and they maybe been vaccinated at their home site, it was actually difficult for them to find where it was and get access to the vaccination sites. And you can see how those are all categorized. And then those need to be prioritized. And once these are prioritized, then we have some real clues as to what we need to do to intervene to change the behavior. And it may be that we need to address all of these, or just one of these, but, and then maybe that we need multiple interventions. So the point of all of this is that of going to a lot of effort to diagnose the behavior that we want to change is that behaviors are often complex and influenced by multiple factors. And something like the COMBI framework, there's a more detailed one even than that called the theoretical domains framework, for example. But using a framework helps us to unpick those influences with a systematic approach and gives us a more comprehensive understanding of the barriers, of the behaviors that we want to change. And the point of all that is that behavior change is going to be more likely if we target the influences on the behaviors. If you just go back to this example here, and we focused on, for something like knowledge of how to book and how to get a vaccination, we kind of pushed those messages, but we didn't address access, or we didn't address trust or risk perception, then we might not expect to see much change. So then if we think about design, and how do we go from those insights to intervention, one of the key concepts in behavioral science I think that's really important for us to keep in mind is this intention-behavior gap. We've talked about it already earlier around physical activity in terms of that we've got that strong intention to behave, but we don't actually manage. Even when we change people's minds, their behaviors don't change. So we can think about different types of policy options, particularly if we're thinking about national Ministry of Health. What are the different policy levers? What are the different tools we have at our disposal to drive change? So in this model of the behavior change wheel, we have capability, opportunity, and motivation, that model of behavior at the center of the wheel. And then there are different interventions we can use, such as persuasion and enablement and education. And then the policy options are our sort of policy levers, which are listed on the right-hand side. We need to think about which of those is appropriate, which of those are we use, which is the mix of those that is appropriate for the behavior that we're working on. And there's some key tools as well that help us think through if there are certain barriers and enablers, more about capability or opportunity or motivation, then there are certain things that are going to work or not work. The green boxes show where there is evidence. This is an evidence-based approach, whereas evidence from public health interventions that those types of interventions are effective in addressing those types of barriers or enablers. So for example, if we have a problem of opportunity, the sort of environmental aspects, again access, then persuasion and education are not going to work. But if it's an aspect of motivation, then maybe education and persuasion are some of the right tools. It's just helping us think through how we design our interventions. And what it looks like in terms of application, and Dr. Fadi will sort of give you some great examples more from the local region. I'll just touch on this a little bit here around some of the different types of interventions. We can use fiscal measures, so taxes, to drive changes in diets. And a really interesting point, we had a workshop about this the other day, so apologies for those in the audience who were at the workshop too, but really interesting aspect of this is that it drives change of behavior amongst the retail industry and the sort of production and the manufacturing industry, as well as the public. So there are costs for industry that they want to avoid, so they reformulate their drinks, as well as people seeing a cost difference when they go to the supermarket in those drinks, which might drive them to choose something that is also healthier. This is an example of incentives. So again, sort of financial things, but sometimes very small incentives can be really effective and drive substantial change. This is an example of obviously picking up HIV results. A small incentive worked, and increasing that incentive didn't have a huge amount of difference. So when we get good, robust evaluation, it also helps us know the price point to work at. Defaults, this is where, for example, people have to opt out of a service rather than opting in. So if you have to maybe opt in for your HIV test results, we see maybe 8% of people counselled, 7% tested. If they opt out, then 21% of patients were counselled and 20% were tested. Defaults can be a very strong type of intervention. We can also use framing, things like loss aversion. So when communications reminded individuals that flu shots were waiting for them or reserved for them, they proved much more effective. And this is based on the theory that we value losses roughly twice as much as we value gains. And finally, thinking again about environmental restructuring. There are different ways we can provide foods, offer foods, provide menus, or how we present and cut up foods that make them more attractive, and that environmental restructuring can actually improve the choice of healthier foods. This has been some work, this is a published brief on this from WHO around nudges to promote healthier eating in schools. And just wanted to sort of highlight this. There's obviously a huge amount of work. I think Fadi, you might talk about this more again. Testing in the World Cup with FIFA here in Qatar around these kind of different nudges that can be used. I'm mindful of time, but I'm just going to touch a little bit on cognitive biases and heuristics and why do we need to talk about them, whatever they are. The key point about these, I think, again, there's been a real interest in these fairly recently, as it says at the bottom. It's kind of grabbed people's attention. We have Nobel Prizes kind of won in this area. The point is they cause predictable deviations from what might be seen to be sort of rational behavior. We might look at a sort of behavior and sort of question why people aren't doing it because it seems very rational to do that thing. But actually very many of our decisions are automatic or subconscious. And these things are consistent and proven, so we can draw on this evidence, we can draw on this science when we're doing some work. So this is a really nice thing. I don't know if anyone's seen this before, but again, there's a little bit of audience participation required. This is called the Stroop test. It's just trying to give you an idea around how some of these things work in sort of people's brains. So what I'm going to ask you to do is everybody together say as loud, well, fairly loudly, but call out. I just want you to say the colours, please. The colours from left to right. Just tell me what the colours are. So it starts with red. Thank you very much. It's very easy. Again, if you could please tell me the colours from left to right. Yellow. And last, very loud, please, the last one. The colours, please. I really love doing this because every time we do it, it makes people smile. We always get a little bit of a laugh. And what's really nice is you can feel how sort of different it is in your brain, right? It's just an example. Obviously, this is not a health example. This is just an example of how your brain processes information. And actually what we learn is that when we learn, and when we learn to read, our brain processes those words quicker than it processes the colors. So when you look at the last line, your sort of automatic process is quickly saying green, red, yellow, blue, right? Your automatic response is that you have to kind of override that. You have to think, and you consciously kind of think yellow, blue, red, green. It's much slower, right? You have to engage those processes in your brain. It's just a really nice example. Another one, you don't have to shout out this time, but you just have to put your hand up. If you can put your hand up, if you're a worse driver than average. Nobody. But you understand statistics and proportions and things, right? So actually, it's really interesting because this is around overconfidence and overconfidence bias. If there's the average is 50%, so maybe there's a different selection bias in the audience, but on average, 50% of people here are worse than the average, and 50% of people are better than the average. So this is about overconfidence bias and the tendency for us to overestimate our abilities. For example, when thinking about our health, we might think that we know what we're doing more than we should. Another one is optimism bias. People believe they're less likely to experience a negative event. What this looks like in terms of health, when we apply this to public health and think about something like type 2 diabetes, is this kind of aspect of it's not going to happen to me. That's the optimism bias. Or you have to enjoy life, so why spoil it, worry about the future. That's present bias, living in the moment and valuing what we do now more than what's going to happen in 10 or 20 years' time, thinking about things like cardiovascular disease. So these really, really do have an important effect. So biases are systematic effects on thinking. Heuristics are the kind of mental shortcuts that we take when we kind of solve problems and make judgments quickly. And it's really important that we do that because we face so many decisions every day, like hundreds and hundreds. So we have to, like evolutionary-wise, we have to be able to use those heuristics to help live our lives in a kind of ordered way. But because they explain how our mind works, we can know that actually that, again, coming back to this point about simply telling people is not enough. We can use these again to change people's behaviors. And we can design, if we design programs, if we design policies and health policies where we expect everyone to behave rationally and do what they're told, do what they're told to do, they might not be as effective as we hope. So just, I think the sort of the closing section really, or coming towards the end, just thinking about the importance of data and evidence and evaluation. So a bit about how. Again, I showed that example of COVID booster vaccination. You're probably very familiar with these, the different sort of types of evidence reviews, qualitative, quantitative, and obviously mixed methods. Different methods are better suited to gather behavioral insights at different stages of the process. But again, a call and a push to kind of go beyond some of those CAP studies. And when we think about that in this DDDIE framework, this is what it might look like in terms of some of the different approaches. We're not limiting to these at all, but some of the approaches that might be best suited to those different stages. So when you're really trying to understand the problem, looking at the evidence, maybe analysing existing data in the country, then we might start to kind of add in more qualitative work, surveys, to really understand specific population groups, specific behaviours, where there are gaps in broader evidence and data. And then when we think about designing interventions, we might again look at the evidence reviews about what works. So if these are evidence reviews maybe about the behaviours and what drives behaviours, these might be evidence reviews about interventions and what works. And we might use qualitative and experiments to kind of pilot things. We might have online experiments to test things out. And then we might go into randomized controlled trials, lots of different evaluative techniques we can look at to kind of see whether something works. And then, again, think about kind of qualitative, quantitative, and randomized controlled trials for evaluation. Again, RCTs are under implementation because you need to deliver the program differently if you have a randomized control than a different technique. Just to kind of skip through this very quickly, again, I guess it makes the same point that routine data and observation can help us understand behaviors, focus groups more about maybe why people behave the way they do, surveys to look at the beliefs and intentions across different subsamples of the population, experiments maybe to look at measuring capability, motivation to do things, and maybe randomized controlled trials to see whether something works or not. Just again, some rules of thumb. And I'd just like to sort of bring back to the frameworks again, because again, that additional line is more the theoretical domains framework. But the point in this slide is really that we can use the frameworks to collect information and analyze the information. We can come up with some good ideas about questions that might be useful to ask, but if we use a framework, then we're much more likely to be comprehensive in the data that we collect, and then we can also analyze it. A framework analysis of the data is likely to give us a really good understanding of what is driving that behavior. And again, with the intervention. So we can really use those frameworks and theories in the data process as well. So, coming to an end. We have great support from leadership across the world and across countries. That's Dr. Tedros, our Director General at the WHO. He's been incredibly supportive, like taking a personal interest in support, and he regularly meets with the Behavioural Insights Unit to sort of support the work. You can see the statement he's making there about the potential, but also understanding it's not yet an integral part of practice in most public health work. And there are some barriers to that, and that's what we're trying to address, and the World Health Organization is here to provide some support to countries. Dr. Roberto mentioned the global resolution on behavioural science for better health. That was kind of proposed by Malaysia, the minister in Malaysia, and it was co-sponsored by Qatar, and your Minister of Public Health in Qatar has been very supportive of this. So, final slides really about 3 ways to change behaviours effectively. Be specific about the behaviour. We talked a bit about that define process. Think about the barriers and enablers. Oh, jumped. Think about the barriers and enablers, that diagnosis process, and bring theory in as much as possible, and use evidence and data. There are 3 key things, 3 kind of lessons. Those might be some of them. And the behaviours are part of the problem, but also part of the solution. So we use behavioural insights to understand who needs to do what, when, how often, with whom, and why they're not doing it. That's the behavioural definition and diagnostic. And there are frameworks. We talked about COM-B today. Also, when designing solutions and evaluating efforts, we also kind of design behavioural interventions, and we talked about some of those in terms of whether you incentivize people, educate, change the environment, for example. So, why do we need behavioural insights? Many interventions rely on education. People have limited time, energy, and mental resources, and sometimes we forget that, and also physical resources. They often fall back on habits, automatic responses and biases, and behavioural influences are not always obvious to us, so the common sense solution may not always be the most effective. Thank you.
Okay, thank you very much, team. If there is any very burning question, we can do it now. Otherwise, we are thinking to have a question and answer session after the next presentation. So, okay. And after the end of the seminar, there will be possibility to interact with the presenters. There will be there is some food upstairs that you know, and we want to nudge you to move so you can go up the stairs. So that's okay. Thank you, Tim. We will keep the time for some questions later. And I'm super pleased to invite Fadi Maki, behavioral science expert at Boston Consulting Group's Behavioral Science Lab. Okay?
Voila.
Very good. Okay, so Fadi, the floor is yours, and we will...
Thank you very much, Roberto. Good morning, everyone. It's a great pleasure to be with you today. I think Tim covered it all, so I'll focus on maybe some applied cases that we have been doing in Qatar, just to give you more perspective. But I would like to start with another quiz similar to what Tim did, which is, can you name one or two people who won Nobel Prizes in economics for their work on behavioral science? I'm sure you remember at least one recently. Richard Thaler, right? Who else? Huh? Exactly. But although he won it for one particular, I consider him a behavioral economist. He won it for mainly his work on experimentation, use of RCT. But Danny Kahneman is another kind of figure. And people forget about Herbert Simon, who was the first to talk about bounded rationality. Tim talked about the intention-action gap. If we're thinking about something, then we think in our mind that we will make a decision, and then from decision go to action. So thinking, deciding, we think that it's straightforward. It's not. From thinking to deciding, we go through a variety of biases, maybe mental shortcuts that affect whether we take the right decision. And even when we take the right decision, and that's where this is very interesting, we go through also a lot of biases that keep us from taking the right action and following through. So hence the intention-action gap. So give the example, particularly from NCDs. Take the example of present bias. This is what we basically, where we seek immediate gratification. We care about the immediate. We don't see ourselves visiting the future, where we don't see also the effect of some of the unhealthy behavior, like eating that chocolate cake or not kind of doing that physical exercise. So that kind of creates that bias to the present and makes us not see the problems in the future. The same thing about status quo, which prevents us from actually doing the right decisions, going to physical checkup, being overconfident, like Tim mentioned about things happening to others, not to me. I'm immune to that, and overestimating probabilities of harm happening. So if we don't take these into consideration, what ends up happening is that we will end up coming up with rules and regulation that never get implemented, at least not on planet Earth. They might be implemented somewhere in Jupiter and Mars, but not on planet Earth. And that's why we need to take those into consideration. Before the rise of nudging in behavioral science in public policy, the typical levers for changing behavior were either command and control. So if you don't do this, you'll be sanctioned, you'll be given penalties. Or every time you do something nice, we're going to reward you. Or just health promotion, give brochures, give information. And people are rational. They take the information, process everything, and act in their best interest, and we live in the best of all worlds. This is unfortunately not true, and systematically not true. That's why we are seeing more rise in use of behavioral science-based tools such as nudging. Simply defined, nudging being small changes in the way we frame the options or the decisions that gently steer us in the right direction without forcing us, and while still being cost effective. So this has been put forward in a very eloquent way by Cass Sunstein and Richard Thaler. Richard won the Nobel Prize soon afterwards. Examples of that: a timely reminder, a switch of a default, an update of people's perception of what the norms are example of nudges. Heavy tax, heavy subsidy might not necessarily be. There's been a lot of rise in what we call nudge units or behavioral science team, and proud to have been part of that movement in Qatar, which led the way in 2016 at the Supreme Committee for Delivery and Legacy, setting up the first unit just before, 1 year before Richard Thaler won the Nobel Prize for his work on nudge. And since then, we've seen a lot of units kind of really happening around the Arab world. But of course, the first such nudge unit happened probably with David Cameron, the Prime Minister of the UK. The President of the US also did his nudge in it. But we've seen it now spread, but now what we see more is ministries of public health acting and kind of developing and setting up behavioral science unit, and a lot of healthcare stakeholders, such as hospitals, such as health insurers, such as philanthropies working in health, NGOs, and so on. So this is really spreading very fast. And essentially, to recap, we do three things in a nudge unit. The first thing is that we dissect the challenge so that we are able to see the examples of the biases that Tim talked about. We dissect those, we see what get people to tick, what get people not to do what they're supposed to do rationally. And then because of that superior sight and understanding of what drives people's behavior, we are in a better position sometimes to design solutions that are informed by behavioral science, such as nudges, that sometimes could be more effective than the typical conventional levers. And what makes us a proper nudge and behavioral science team is that we test and test and test. And we borrow that from the medical field. We do randomized control trials to test what works. And this is, of course, fascinating to be applied to policies, not only in the medical and pharmaceutical fields. So there are so many types of nudges, and what I will do is take you through some examples of experiments we've been doing. And actually, I've just been looking, Roberto, we've done about 10 of those together over the last 3 years with the Ministry of Public Health specifically. So COVID, there's been a lot of COVID experiments, but there's been also a lot on healthy eating and so on. So what I will do is start with a few examples of nudges, just to show you how sometimes a small change in the way we frame decisions could be very powerful, such as choice architecture. This is a very good example in 2017 that we did, in really training the call center before we started seeing platforms for delivery that are online. You just call and ask for food delivery, and what you get with it is plastic cutlery. So what we did is just train the call center just to ask, sir, do you need plastic cutlery? That question, which is a nudge to push what we call an active choice, dropped down the delivery of plastic cutlery by about 76%. And more importantly, it earned us a nice tweet from Richard Taylor. And that was, as I always like to laugh about it, a few months before he won the Nobel Prize. So I don't know whether it's causation or just correlation, but I mean, he got the Nobel Prize. This is a few years later, working with Talabat, where we just went to them and said, can we switch that default? They were a bit concerned about initially switching the default because they were caring about customer satisfaction. So what I want to show you initially is that this is the typical setup. If you do not need cutlery, slide left. So that means you are getting cutlery, but if you don't need it, you can switch the default. Guess how many switch the default? Only 10, 11%. But if you change already the default and say you're not getting plastic cutlery, but if you want it, switch it on. Also another 10 magical number. Switch the default. So fascinating how we are going with the default. Somewhere, somehow, people are choice architecting. And we are, because we like status quo, because we don't like make decisions, we flow with the default. So if we know this, there's so many opportunities for us to design options whereby a simple default. It could be with patient care. It could be with medical doctors as well, changing the default of what they could do that with generic drugs and so on. So much to be done. Another example of sometimes a gentle reminder. This is the advantage of being in a FIFA World Cup organizing committee, where we had the opportunity and the honor and the pleasure to conduct experiments during the event. So this is a simple kind of experiment where we randomly assigned different sections of the stadia to control and treatment. And the treatment got that kind of floor kind of sticker saying, wait, please don't leave your waste behind. Almost 18% reduction in terms of waste between control and treatment. We did something similar whereby we put a QR code that was in the Club World Cup, so 2 years before the World Cup. And basically what we've been doing as BFIT development, we've been doing so many testers in the event before we ran to the World Cup. So a simple QR code that primed people about certain environmental question had an effect in how they recycle their waste afterwards. So you see, we had the QR code in some section of the stadium and not with others. But something else we did is that we measured during halftime and during post-match the sorting behavior. As you remember, we had two types of bin, recyclables and non-recyclable. I'll show you in a second how something very interesting happened by trying to understand. We did a small cap survey during the event, also to know not only what they say they're doing about recycling, but what they know about recycling. So it seemed there was a lot of knowledge gap there. And I think, let me just move to that one. This is one of those surveys that we've done that showed that we asked them where 5 items that are typically distributed in the stadium, where they should go, in recyclable or non-recyclable. And guess what? Only 11% knew where to recycle all 5 items. So it means, yes, we did a simple nudge afterwards to check, to nudge people to do the right thing, which is we randomly assigned bins into control and treatment, and the treatment just said, do good, recycle right. Just kind of that extra moment where you're asking someone to think about what they're recycling. It was effective, but clearly the knowledge gap was significant. And this is the importance of trialing and testing earlier so that you know where to focus on. The fascinating thing is that with Maya from Qatar University, we ran a small experiment, but that was 2 years later, with students of grades 9 and 10. And actually, on the dirty plastic cutlery, they scored higher than the fans. Now, it's not kind of perfectly comparable. It happened 2 years, but still, it showed that the kids of grades 9 and 10 from a particular school, there were about 150 of those, scored higher, knew more where to recycle the dirty plastic cutlery. The rest were similar or slightly lower. That's another experiment I want to show you, not so much not related to health, but related to the concept of commitment and priming with commitment. People like to feel that they are kind of following through on their intention. This is one of the experiments. Actually, a similar one was done and was retracted. If you remember, some of you, the commitment done by, I think, Dan Ariely and Francesca, I can't remember her surname at Harvard, whereby they moved the signature in filling questionnaires from the bottom to the top, just to create that extra attention to us doing the right thing. And then the results showed that switching that signature to the top made people more careful about the correct information they provided, but that was retracted. But we did it and did replicate. And this is actually done during the FIFA World Cup, whereby we realized that a lot of the volunteers who wanted to work in the World Cup would be overstating their capabilities with language skills. So basically, we asked them, how's your language? Of course, it's great, native, super professional, and so on. So we did something similar. We randomly assigned the volunteers. It was a large sample, fairly large sample size. We randomly assigned the two groups. The treatment group got a simple commitment box whereby we asked them to click and say, by click into this box, I agree to tell the truth during this application. Fascinating result because it shifted those who had that treatment were less likely to say we're native or we're professional in the language skills, and shifted them more towards none or basic language skills. So great example of sometimes how you bring in, and there's so much where you're filling the application form and you bring in that form, that tick, that priming about commitment to kind of promote honesty. In the case of COVID, this is where there's been a lot of innovation with behavioral science. It was really accepted big time that this is important, partly because before the vaccine was created, behavioral science and behavioral intervention were the only solution, by and large, to stop the spread of the disease, right? Unless, of course, you wanted to go the draconian way. But otherwise, you need to use behavioral science, be informed by insights from behavioral science to get people to self-isolate, do social distancing, continue doing the 20 seconds. So there's been a lot of that. And even during the pandemic, you had to work on behavioral science, particularly to facilitate access to, for instance, mental health support. And the uptake of the vaccine, clearly, there's a lot of behavioral things, unless, of course, there's so many convictions around it. This is one experiment that we did 2 months before the pandemic. Fascinating. That was done in the Supreme Committee, where we were also already pushing for people to sanitize. There were hand sanitizers in the various floors of the Supreme Committee, if you've been there. And we tested a control group versus 2 types of messages. One, a kind of a salience type of nudge where we put bubbles on the floor, priming people with the soap, with cleanliness. Another one, kind of telling people, let's sanitize. People here always sanitize. And the interesting thing is that both did better than control. This is one of the experiments to show you another type of nudge, which is social norms. We like to follow kind of what others do. And we normally that has an influence on what we perceive the reality is and what we actually end up doing. So, of course, there's a lot of stigma, still is, but that's kind of coming down in a significant way. And people don't necessarily trust to speak to online support, particularly on mental health, which became very pressing during the pandemic. So a treatment group in that case got the reassurance that the perception or the actual reality or the actual norms of the use of online services has been increased based on data that we got from the Ministry of Public Health, which led to an increase in trust in those by an equivalent of 34%. During the vaccination, when that started, there was so much done, of course, because there was hesitation. There was a lot of knowledge gap, right? People don't know, what is this vaccine? How does it work? Is it messenger-driven? Is it kind of a typical vaccine? Am I willing? Is there risk perception there? How do I register? And if I register, do I show up? So really, if you break down every one of those stages is a perfect example for bringing behavioral science to facilitate, for instance, information about knowledge and so on. And we ran so many experiments with particularly the Ministry of Public Health, one on salience of the vaccine, one on the social norms that has changed to get people to vaccinate, another one using the effective messenger, His Highness the Emir taking the jab, we've seen that a lot, or using emotions. So all of those, we've seen a lot of innovation in behavioral science using those. If we go to non-communicable diseases, I feel sorry for some of those who attended the session 2 days ago, but I'm trying to still bring in additional information. So in NCDs, the typical 3 stages of the behavioral pathway essentially are prevention, so addressing the risk factors, right? Eating healthy, doing physical activity, and so on. So that is the first stage, to minimize the risk of developing non-communicable disease. Of course, it's not a guarantee, but it minimizes, and we address the risk first, and you do that by eating healthy, physical activity, and so on. And the second stage is how early do you detect incidence of this disease? And basically, there's so much to be done, not only to make it easier to deal with, but also to make it less costly from a public finance point of view. So much now effort is focusing on the second stage of the non-communicable disease, namely the early detection. And finally, it's about adherence to the protocol, taking the medication on time and taking the right medication and so on. So really, it's kind of, when you look at a behavioral challenge, you break it down, you look at the user journey and try to see where are the entry points you could come in from a behavioral science perspective. And that's part of the work that any behavioral science course does, and that's what a typical behavioral science team does before starting to address. I just brought in this slide because I saw my colleague Maya, who's going to be a future also co-author. This is one of the experiments we've done with Qatar University and the Ministry of Public Health. That was a month before, right? A month before the World Cup. And basically where this is, it was a sample of 148 students, grade 9 and I think grade 9 and 10, grade 9 to 11. But basically we gave a small commitment card to a treatment group just to say, I promise to eat fruits and vegetables, which had an amazing impact on increasing a willingness. So of course, it's the early stage, it's not yet behavior, but working sometimes on that willingness is a proxy for the behavior. So we need to work across the board, across the journey, not only wait for the behavior. And this is the same group where we did the survey to understand the knowledge gap, where they performed better than the fans on knowledge of where the kind of dirty plastic cutlery is to be done. This is another experiment, a set of experiments we did in Qatar with the Qatar Academy for Science and Technology and Qatar Foundation, where it was really a true kind of pleasure teaching students, basically grades 9 and 10, behavioral science over 3 months. And every one of the 3 groups we taught, we gave them the chance to conduct an experiment. And the experiment was to think of nudges they could use in the stairs leading to the parking in Qatar Foundation. And we did the co-creation with them. We installed the people mover, people checkers, so that we know how many are going. And fascinating, all of them outperformed control. So all of them did very well. Some of them used the gamification, some of them used the kind of calorie count, some of them used the active choice. So it's fascinating. Just 2.5 months after a course on fundamentals of behavioral science for students, this is what we end up doing. So fascinating, and imagine what can be done with kind of older students, such as university, which we've done actually with HBKU, one of the earlier courses, experiential courses to be taught in the region. Now I'm going to show you an experiment that we've done with the Ministry of Public Health and the WHO, which is during the FIFA World Cup. So basically what we've done is also very important because it was the first time behavioral science has been integrated in a systematic way in the FIFA World Cup. So FIFA was very, well, was not initially welcome, but at the end they were kind of receptive to the idea of trying, but of course we had to work with the sponsors, the contractors, those who provide the food. So at the end we managed to get a commitment that 30% of the food items on the menus are healthy, as certified by the WHO. Some items failed the test, and therefore they're not part of the 30%. But basically, from the food that you saw and you consumed, 30% of them were healthy. And the second thing we did, we reordered the food based on their healthy content. So we put beef burger in the hot sections and hot dog and beef burger at the lowest, and put the fatayr or the healthy on top. And that's in line with some experiments that were done, even in a kind of McDonald's, where simply changing the order of the Coke Zero shifted people's consumption to that in the choice architecture. So the choice architecture reordering was the second thing. And the third thing was that the salience, the visualization of some of the items. So we highlighted those healthy items without saying that this is healthy or this is calories, because we've seen sometimes it's counterproductive to do that. So we just highlighted them. And then we placed some wobblers dangling from the ceiling of the healthy item. And these were in 974, for some of you who attended the game, and in Ahmad bin Ali Stadium. These were the treatment stadium versus the control. And while this is preliminary, the results show that all treatments were effective in the use of this ordering, salience, and the visuals in the consumption of the veggie sticks, the healthy fatayr, and the vegetables. Another example of NCDs, and I think I would like to, and soon, is an experiment that was done in the marathon. So before the marathon, people came to collect their kind of vouchers and numbers and so on. But there was a lot of kiosks where we invited people to kind of test whether they have high blood pressure. What was fascinating is that, and we asked them whether they think they had high blood pressure. Of those who had high blood pressure, only 76% were unaware, which is fairly high. Normally 49, 50 is considered high. 76 is extremely high. And basically randomly assigned both in two groups. Some of them were asked to check again with their medical doctor, because one reading is not enough, but the second one were sent the reminder with the reading. And the effect was significant for those who received the extra reminders. Small things, but these are the toolkits that we could use as public health professionals to kind of promote certain effects. But what takes us, I mean, those experiments, a lot of you might say there's a lot of selection bias. These are these are pilots, true, but they are very informative. But to take this to the next level, nudges, I always say, are not enough. They are complementary to the policy tools in the hands of healthcare professionals. In particular, we need to provide capacity building for healthcare workers, people involved in healthcare value chain. There has to be use of smart technologies, such as the ones I mentioned. We need to sometimes work with industry behavior, because reformulation could be more effective than nudging only consumers on what to choose. So shifting kind of the salt content in food or the sugar could be sometimes more effective. And we need to find ways to nudge industry, and sometimes not only nudge, but just force them to reformulate, and sometimes by being smart about the taxes, how we frame the taxes so that to avoid the high incidence, they kind of shift and reduce their sugar content. That's a very good example of the sugar tax. That's the behavior informed tools. I want to just stress again the importance of what the WHO did in this behavioral science for better health, which is started with President Obama in 2015, 1 year after trialing and testing with his behavioral science unit at the White House, which he created. He issued an executive order, 13707, in which he called on federal agency, government institutions to use behavioral science, to review their programs from a behavioral perspective, to integrate behavioral science capabilities into their programs and work. Fascinating call on government to integrate behavioral science. The UN Secretary General did that 2 years ago also. Asked every single UN agency to do exactly the same in a guidance note. And this is what the WHO just did 2 weeks ago, which is a historical moment for all behavioral scientists, because it is really placing behavioral science at the top of the policy tools and just telling ministries of public health, telling also healthcare providers, health insurers, to integrate behavioral science into work, set up the I function. That's what the Ministry of Public Health is doing. Recapping. So, particularly with health, it's a policy challenge that has behavioral components, strong behavioral roots. Behaviors at the heart of health challenges. And therefore, conventional weapons on their own are not going to work. However, this is behavioral science. Tools are complementary, cannot be used as an alternative. So we don't stop doing everything else, we use nudges. No, we learn how to use nudges in behavioral intervention to complement what we're doing, to increase the compliance, to increase the impact. At the same time, so we are at a stage where we're seeing an amazing change in the mindset of policymakers. So everybody's accepting and willingly going for the whole concept of behavioral science integration, of experimentation. But that, with this mindset, there is a need for a change in skill set. That's why capacity building is extremely important. That's why holding this seminar in a university is extremely important, because there are partners in scaling up the use of behavioral science at the population levels. Not only, we've done it at school, we've done it at university, but that should be scaled up even more. At the same time, a golden motto of ours is context matters. So what works in one place might not work in another, and therefore we need to constantly experiment. It becomes an eternal lab. Experimentation is not an afterthought. We were just discussing about this. It's not like when you do a strategy, after you do a program, you see how you could integrate behavioral science. No, you have to start earlier on, integrated in every stage of the programming and the implementation. And I think the implementation is key. There's a lot of now implementation sciences around exactly turning those strategies into actual implementation. Behavioral science teaches and taught me for sure humility. What works is not what we think works, but what is tested to work. Oftentimes we're wrong about what we think will work. Before we ran a trial, we have multiple arms. We wonder which one works. Funny enough, often we are wrong, because like our belief, our perception might be not the same as the reality. So that is what I want to say. Endorse behavioral science, use it, but remember to use it for good and use it with responsibility. Thank you all. I sit there.
Thank you very much, Fadi. This is very...
So, I personally studied economics and public policy and law, and then studied later on behavioral science and took courses into this. But I was taught the rational, the kind of conventional ways of studying economics, that people are rational agents, which turned out to be a lot of not necessarily true. So really, I had to undergo a lot of adjustment in what I learned, rethink a lot of my hypotheses. But nowadays, if you're studying behavioral science, you could study it from so many different angles. You could study it as a public health professional, as an environmentalist, as an economist, which now integrate behavioral economics into it, as a sociologist, as a psychologist, as an anthropologist, as a neuroscientist. effectively every single area of study can have a behavioral science angle. Of course, we are in a health community, so really public health could be kind of an amazing place where behavioral science could be integrated in the various departments that you are giving.
From my side, like the slide I showed, and I absolutely agree with that, there's so many different disciplines that we can bring in, whether it's more sociology, behavioral economics, whether it's more psychology, etc. Personally, I did a master's in infectious disease control, and like my PhD is more population health. And I, as I said before, I worked through sort of epidemiology and quality improvement before I got into behavioral science. And I think it's part of this growth that has brought people in. But when I've been building teams, I've been much more keen to recruit people who have a specific psychology, behavioral economics, sociology, specific disciplinary background. I think if we're thinking about the technical expertise in this area, then bring in the experts. Our teams are quite often multidisciplinary. So the team I built and I was part of, I was very much had the public health experience, the research and evaluation skills, with some of the knowledge and growing knowledge around behavioral science. But I had people who had PhDs or doctorates in health psychology who are really essential, I think, for building this. And we work very, very closely with academics. Much of our work was done in partnership with academics, some of it on commission or some of it just in partnerships. And the Department of Health and Social Care in the UK has a policy research unit where three universities actually come together to bid for their contract, and it's a 5-year contract. And again, they have multidisciplinary teams across some of the disciplines we've been talking about, that sort of come together and provide responsive advice. They work on sort of long-term programs of work on sort of policy priorities, but also provide something like a quarter of their work is kind of responsive advice to the ministry. So it's the internal expertise of the team, but also bringing in very much academia to the policy world or the policy programs.
Okay. Any other questions? There's a question here. Yeah, this gentleman here.
First of all, I'd like to thank both of the speakers for the extremely interesting topics that you presented today. I've learned a lot personally. My question is to the second speaker, Mr. Fadi or Dr. Fadi. Apologize, I didn't catch your credentials, but you've presented very interesting examples on changing the order of certain items to influence behavior change, or how changing the default, and particularly for talabat, which I personally noticed when I was ordering food. And you had mentioned that there were some concerns regarding potential changes in customer satisfaction. So my question to you is, was there some negative feedback from changing the default? And if yes, how? What are some mechanisms that you implemented to reduce that dissatisfaction or increase the awareness about the importance of being more environmentally conscious?
Right. So I might have mentioned 3 examples related to the use of default active roles. The first one, before it became online platform, where we're still working with the call center, the restaurant chain insisted on a sentence saying, for environmental purposes, we want to ask you if you want to do that. So they were already concerned about this, and they wanted to make sure that kind of the customers are not unhappy. So they put that themselves. In the case of Talabat, in the first experiment we did with them, they said that we don't want to start with the more aggressive one. Means like you don't get plastic cutlery and then you could opt into it, because they said there might be customer satisfaction. They had their own assessment of that. And nowadays, I think they've changed, because initially they said, no, let's just see how many. And it was shocking for them as was for us. Only 10% kind of really opted out. Not probably because of customer satisfaction, but because of laziness, because of going with the default, going with the status quo.
Thank you. Please.
Hi. Thank you again for a fantastic presentation. My question is behavioral science has been used extensively in economics, and it's being used by the banking industry and advertising agencies. What do you think accounts for the lag in using it in public health and medicine? And what types of barriers are we encountering? How can we overcome those?
Thank you for this question. I think I had this in mind all the time. So please, team.
It's a great question. I'm not sure if it's true, actually, to be honest. I mean, I think it's very interesting. I mean, definitely, I think in marketing there's been a big push, and to some extent, often public health took on some of those lessons of social marketing in the past, and to some extent this is a kind of a development in those areas. But I remember 10 years ago when we started some of this work in the UK government. And we met with pharmaceutical companies and insurance companies and some others, and some of the sort of big consultancies. And actually we were ahead of them. So the public sector was actually ahead of industry, really, in some of these areas. So I think it depends where you are, and it depends kind of, I mean, and many things, it depends on sort of leadership and individuals who have taken something. Fadi's done a huge amount in this region to kind of bring behavioural insights into different organisations and support that. So often it happens that way, and I don't think it's a uniform development, but I think in some areas the public sector has been ahead, and in some areas the industry has been sort of catching up. That's more on the behavioural insights and the sort of the latest sort of behavioural science. I mean, I'm not talking about marketing as such.
But Tim, there is it's normal observation from each of us as consumers that the pressure that you get from the supermarkets, for instance, or in some messages coming in, all the time on certain products is actually there. So I don't have evidence, so, but I tend to agree with this impression that there is much more sophisticated use of these tools in the private sector.
I think in some, I mean, supermarkets is a great example of probably where that is, but still, we had conversations with supermarkets. We did experiments in supermarkets. Their knowledge of the science was lower, let's say. So yes, they use the techniques, but it's sometimes quite basic. It's like, who's going to sell more of this? Okay, we're going to put this here. More people buy it. Okay, that works. So we're going to check. It's very kind of just iterative learning about what works. And obviously, there's a huge amount of competition between different supermarkets. And yes, I mean, in terms of the market, I don't have a strong background in marketing, so but it was really interesting to go and work with supermarkets and find out the way they work was very much a kind of just changing small things, like particularly online.
So it was not empirical.
And they just learn and they do things and they find out if we put things on the end of the aisle, we get a huge uplift in our sales. So they sort of do that. And if we put things at the back, people have to walk to get the bread and milk at the back of the supermarket. They have to walk past everything else, walk back past everything else. We've put sweets at the checkout. People are going to be waiting at the checkout. They're going to buy some sweets because they're hungry. But I think a lot of it is kind of learned by doing, and the data. I mean, huge amounts of data collection and that kind of approach, rather than the sort of theory and the science. And it's so driven in terms of specific. I mean, there's almost one behaviour, which is buying something. They don't really care what people buy as long as they buy something in a supermarket. And so it's so much more easy in a way. Like health is such a broad array of different people involved in health and different actors and different contexts. It's so complex.
Can I ask a question to you, actually, university? If somebody is a student here in Qatar wants to learn behavioral science, I mean, does he or she have this possibility? At the College of So it's not a master in behavioral science. Okay, that's interesting. Fadi, you have a comment on this?
Yeah, so we did one course with HBKU on behavioral science as a trial. That was already 2016, 2017. That was great. And we did the CAST course. We've run it in the region, in Kuwait, in the American University of Beirut, in the Lebanese University, and even in Pakistan. So we've been running those courses both in academia and in kind of kind of executive setting. But what we need to see is more uptake of these courses, more streamlining, more integration as part of the curriculum. Could be in multidisciplinary offering, but kind of kudos to having this integrated university. No pressure, Dr. Hanan.
Yeah.
Can I mention one more thing? I mean,
Sure.
just throwing that. I mean, I mentioned some of the relationships we've had with universities, but also we've had great. I think we talked about this with Fadi as well. Great value from interns, PhD students who have come, spent time working in policy, given them a great insight to sort of the policy process and the timescales and the multiple different projects that are going on at the same time. But it's really kind of created that. I mean, internships are another great way to kind of both build capacity, but also bring capacity into the Ministry of Public Health.
Yeah. Other comments and questions? Okay. Right. I just wanted to share with you a reflection. I was thinking that, you know, when you were making this presentation and illustrating all these different techniques and very systematic review of the behavioral dissection of the behavior and the different components, I mean, this is done for a good purpose. I mean, for you know, for improving health, for creating more well-being, and so on and so forth. But there is also the other side of the coin, the evil side of the coin. I mean, the people who are actually using this technique, not in public health, hopefully, but in other sectors, to change behavior to another direction. I'm constantly having in mind the I don't know, so the advertisement of sweets or of ice creams, or that you know, if you go to television, I don't know many, but many of these advertisements are actually in this direction. So how can we contrast these type of things, which are pretty common? Team, please.
I'll start. Paddy may want to come in. I think this is, I mean, it's a great question. I mean, we know about this probably if you've read about sort of commercial determinants of health, as it's often called. I'm sure there are different factors, but where, and actually it was really interesting in COVID, actually, I was working in the Cabinet Office in the UK, and we had to think when COVID hit, for example, sorry, I'm going off on a little bit tangent, but when COVID hit, we had to think about the health benefits versus the economic benefits and the social benefits or harms. And we had to do some work around sort of systems thinking around what are the different ways in which different interventions or different things are going to have harms or benefits on the economy or health, etc., or the social welfare, social good. So we do need to think about these things, and sometimes we don't think enough, but I think public health has been more and more thinking about the commercial determinants of health and how to tackle them. But obviously there are sometimes competing interests between different ministries in terms of kind of economic benefits versus health benefits, and we have to kind of probably try and surface those. We can do those through research and evidence, and we can sort of think about those things. And at the end of the day, it comes down to political decisions, political will, but we can, as scientists either in academia or scientists in policy, we can put that evidence to policymakers, and they have to kind of really make a decision. In COVID, obviously, the health factors outweighed the economic thing.
Yeah.
And people had to stay at home and couldn't work, and the economy took a hit. And the same might happen, and sometimes the economy has to kind of adapt and change to a new, if we're going to tackle cardiovascular disease, we're going to tackle obesity, we're going to have to do something about the obesogenic environment. And we know that, but there's still not really the political will there normally to kind of address that. There are kind of things that are done in terms of restricting advertising, and things when we come to the evidence, a lot of behavioural social science has kind of demonstrated how things work and maybe what won't work. So telling people part of what we can do is say, telling people it's unhealthy is not going to work. we might have to use, as Fadi was saying, to those bans, those restrictions, banning some aspects of advertising on social media, on television before certain hours. You know, sometimes they talk about the watershed of, so children aren't exposed to unhealthy advertising, etc. So sometimes, and that takes political will, but sometimes we can give them the evidence to make those calls.
Okay. Other comments or questions? If not, I would like to give to Fadi and team a last word. You want to lay a last message?
Just on this specific point, if it's about countering the use of some elements of behavioral science, not necessarily for good, not for public policy, not for public health, by a kind of supermarket or kind of private sector, the only way to counter it is that kind of making sure it's being curbed or it's being kind of regulated. But the way to counter it, the way I see it, is to spread the use of behavioral science among kind of academia, among policymakers, so that they could learn about the good uses of it. But there's no way you could stop misuse of that except through by kind of regulating marketing what can and cannot happen. The way I see it is kind of teaching the power of behavioral science for policymakers, for decision makers, for academics, for students, teaching students earlier on so that it's not an afterthought. Imagine becoming integrated as part of the curriculum, things about behavioral change, about experimentation, about causality. This is extremely important to start early on, to be kind of the best safeguard for potential misuse later on.
Thanks for giving me a minute to think. I think the key thing is it's difficult to challenge. It's difficult to challenge the statement that behavioural and social sciences are not used enough in health, public health. If we kind of agree with that statement, then I just like thank you for coming. Thank you for showing your interest. It's going to be such an exciting time, I think, in Qatar, with the Ministry of Public Health kind of developing these initiatives. I think it's a great opportunity to get involved. It's a great opportunity to learn, and there's so much to sort of read. There are courses online. There's so much opportunity here to grab in Qatar that I think it's just an exciting time, and I hope you all get involved. So a bit of a call to action and a call to exciting times ahead.
Thank you very much, Tim and Fadi, for your contribution. So the food is upstairs, so just run over the stairs so to practice a little bit of exercise. Yeah.